This part of the respiratory lecture will examine COPD, which is chronic obstructive pulmonary disease. Approximately 17 million Americans have COPD in the U.S., and it is the fourth leading cause of death in the U.S. It's characterized by a progressive and irreversible flow of air obstruction. When we look at COPD, it basically incorporates a few different diseases. Depending on your source, this can change a little bit. Some textbooks consider just chronic bronchitis and emphysema as part of the COPD category. Other sources sometimes also include asthma, since that is also a restrictive and obstructive respiratory disorder. We think of typically with the patient with COPD that their symptoms continue to cause acute exacerbations, and many of these patients have symptoms that will not only come and go and get worse and then maybe a little bit better, but then some patients will just keep progressively getting worse. The pathophysiology of COPD includes emphysema, which is a patient that has enlarged air spaces. They have air trapping. They tend to have a barrel type of looking chest. It's quite enlarged just because of the changes in their anterior-posterior diameter of their chest due to their particular disease. These patients have problems with impaired oxygen diffusion, which leads to then hypoxemia, air trapping, and those types of things. The alveolar surface walls actually get destroyed in emphysema. The second type of category under COPD, which is chronic bronchitis, is defined as the presence of a cough and sputum production for at least 3 months in each of 2 consecutive years. This constant irritation causes the mucus secreting glands and the goblet cells in the lungs to increase in number, and so ciliary function gets reduced, and that patient has lots of mucus that gets produced because of that. Asthma is considered a chronic inflammatory disease that causes airway hyperresponsiveness, bronchoconstriction, lots of edema in the mucosa, and mucus production. So typical symptoms of a patient with asthma include cough, the chest feeling very tight, the patient has wheezes, and the patient will have dyspnea. This is just showing a typical example of a patient that has different types of disorders, and shows you some pictures of the respiratory tract with a patient that has chronic bronchitis versus emphysema and those types of things, and how the alveolar structure changes with emphysema. So cigarette smoking, air pollution, and occupational exposure are risk factors for developing COPD conditions. And the goal of Healthy People 2010, which when you took community and family nursing, you probably remember, one of the goals is that to see smoking decrease to no more than 15% of the population that's over the age of 20. And as was mentioned in the last lecture, the latest stats are that between 25 and 27% of the population that is adult smoke. The latest data I was able to find as far as stats among high school seniors that smoke showed that about approximately 22% of high school seniors did smoke daily. So this particular slide looks at the pathophysiological changes between a healthy lung and a client that has a lung with emphysema. So note the difference in those lung tissues. The alveoli on the patient with emphysema is very enlarged. The walls get destroyed, and because of that, the patient's going to have poor pulmonary function and poor pulmonary function studies done. Risk factors for COPD include smoking, air pollution, and occupational exposure. Probably about 20% of all heavy smokers will develop COPD, and cigarette smoking is considered the primary cause of COPD in probably more than 90% of all patients that have it. Our nursing situation with COPD is going to include a patient by the name of Mr. Jones, who's 65 and admitted to the ER with an exacerbation of emphysema. He has a history of hypertension that's controlled with Vasotec, and he complains of coughing spells that have resulted in productive thick yellow sputum. He has a pack year history of 76, which remember is the number of years smoked times the number of packs per day smoked, and the vital signs are as listed. Patient does come in with a poor SaO2, 88%, and a temperature of 101. So things to include in the assessment are listed here. Not only vital signs and respiratory pattern and breath sounds, but also skin color if that patient does indeed have neck vein distension or any lower extremity edema, if the patient has any changes in the neurostatus or sensorium, and what the lab findings are, particularly the H&H values, the WBC values, and ABGs and SaO2 values and things like that. Some interventions for your patient with COPD to improve their oxygenation is going to be to try and position them in an upright position. A lot of these patients actually prefer to be leaning forward, almost more like over the bedside table with a pillow, so that it improves the expansion in the chest and allows for more lung expansion for these particular patients. Pursed lip breathing is a technique that can be used to prolong expiration time and to decrease air trapping, which is what happens with these patients. So this type of breathing helps to slow expiration and prevent collapse of the small airways. So please see the referred readings in your Limon textbook for further information on this. And also just trying to have that patient relax their breathing and do diaphragmatic breathing will also help with their oxygenation levels. To improve gas exchange, the patients are placed on many different kind of medications. Please see the handout that has been scanned into the lecture folder for respiratory. Patients are typically placed on bronchodilators. These help to reduce bronchospasms and reduce airway obstruction. They may be placed on a beta-2 agonist, which produces bronchodilation and helps also with dyspnea. Patients may be put on anticholinergic meds. So these anticholinergic meds will cause bronchodilation. Cholinergic receptors in the lung stimulate muscle contraction and mucus gland secretion. So anticholinergics help to relax smooth muscles in the airways and those types of things. So one example of an anticholinergic agent would be perhaps Atrovent or Ceravent. Those are both long-acting medications that help with that. Combination therapies put together both an anticholinergic and a beta agonist, and probably one of the best examples of that would be a medication called Combivent, which is an inhaler. And then the last category listed there are the methylaxanthanes, and those increase respiratory muscle strength and help to prevent respiratory muscle fatigue. And then the patient another line of therapy is to have the patient placed on corticosteroids to decrease all of the inflammation in the mucosa of the airways. And depending on the patient's condition, they may need oral, IV, or inhaler steroids. It just depends on how they present when they come in with their signs and symptoms. You may have heard commercials for Advair, one of the newer inhalers on the market. And just to let you know, this is actually a combination of a steroid inhaler and then also with a Ceravent, which is a long-acting type of a bronchodilator. So it helps the patient so they don't have to do quite as many inhaled meds if they can start to combine the medications within one particular inhalation method. This slide just shows some tips for multi-dose inhaler instructions. So for your patients that are using MDIs, some hints for them would to take that MDI before meals, make sure they've shaken it well before they use it, clear air passages first. They take a deep breath in, breathe it out, and then when they breathe in, they administer the medication and breathe it slowly in. Hold that for the count of 10 seconds and then very slowly exhale. If they need to take multiple puffs of medications, they need to wait 1 to 2 minutes between puffs. And it's recommended that patients, not only children, but adults should also use spacers on their MDIs. Research has shown that they get much more effective medication administration deep into the lungs, and especially for your older population that might have a hard time coordinating all the shaking, inhaling, holding the breath, and all that types of things. The inhalers, spacer is just a nice way to put that on the end of the inhaler, and then the patient can take more leisurely breaths in and out with that. And it's not quite as cumbersome and tricky as just using a regular MDI. Make sure the patient knows that they should wash the inhaler and spacer after use, and to know how to check if it's full or empty. Some other instructions that you would want to teach them on inhalers, just so that that patient knows if it's full or empty. You can tell the patient to float it in a bowl of water. If the inhaler floats vertically, it's about half full. If it floats horizontally, it's completely full. And if it floats to the top of the water, then it's empty. And patients should always make sure they know approximately how much medication's left in their inhaler, so that they're not caught needing it in an emergency situation and not having any left in their inhaler. We're going to say that this particular patient in our case scenario was ordered to take Provenal 2 puffs QID, Atrovent 2 puffs QID, and Asmacort 2 puffs QID. So in what order would you guess that these should be given? If you guessed to give the short-acting bronchodilator first, which is Provenal, you are correct. That's considered a rescue med that opens up the airways very quickly. The next med that you'd want to give would be the Atrovent. This is a long-acting bronchodilator. And then once those airways are really opened up between those two bronchodilators, then we would go ahead and have the patient take the Asmacort, which is the steroid inhaler, and then that will get deeper down into the lungs. Steroid inhalers are considered a control medication. They're not to be used when the patient's having an asthma attack or a wheezing attack. These are more to keep the patient stabilized. So that would be another thing that you'd want to teach your patients, is what's the differences between those meds. And the only one that's going to be really help the patient if they have an extreme exacerbation with an asthma attack is your quick-acting inhaler, and that patient would want to take the Provental, that type of thing. Side effects of bronchodilators include tremors and tachycardia. Many patients feel jittery when they're on bronchodilators, so let patients know that that's a common side effect with them. As far as oxygen safety and patients that are COPD patients and on oxygen, a lot of times patients may request that the oxygen levels be increased. However, remember the pathophysiology of the oxygen drive for those patients with COPD. Remember that their stimulus to breathe is now a low arterial oxygen level instead of increased carbon dioxide levels. That's because over time their body has adjusted to elevated CO2 levels, and their body gets used to having elevated CO2 levels, or those levels on board. So the stimulus to breathe for these patients now becomes lowered oxygen levels. So if we give them high levels of oxygen per nasal cannula or mask, we are essentially going to be wiping out their drive to breathe. So do a little bit of education with Mr. Jones to explain why you cannot increase his oxygen level above probably about 2 to 3 liters per nasal cannula. It's about the most you'd want to do. Remember, high flow rates are going to give higher concentrations of oxygen, but if for some reason you'd have a patient that would need more like 100% oxygen, you're not going to be able to do that through a nasal cannula. That's something that you'll need to do with like a non-rebreather mask or something along those lines. Other things to teach with oxygen safety: make sure the patient knows there should be no smoking around the oxygen canister. And I think of a particular patient that we had back in the ICU when I worked back there that we would find sometimes when she was brought in that she would admit that she did attempt to smoke around her oxygen tank when it was on. Not typically a good idea for patients for safety. Other things we should look at is the patient's difficulty of breathing. So look for restlessness, anxiety, tiredness, drowsiness, persistent headaches, slurred speech, those types of things, to see if that patient's getting enough oxygen levels, and check that against your SaO2 values and those types of things. To qualify for home oxygen therapy under Medicare criteria, the PaO2 needs to be under 55 and or an SaO2 under 88%. Nursing interventions then for patients with COPD would include smoking cessation programs, increasing patients' fluid intake, teaching correct technique for coughing and deep breathing and use of inhalers, having that patient receive chest physiotherapy and postural drainage to help break up some of the mucus, especially for those chronic bronchitis COPD patients, and to try and balance activity levels with rest. These patients are at high risk for developing infections because they already have a respiratory complication, so make sure they know the signs and symptoms of when they have infections on top of their already underlying chronic condition, to avoid large crowds and high pollen counts, and to get vaccinated, in particular with the pneumonia and flu vaccine, which will help them. Activity intolerance is also going to be a problem with these COPD patients, so make sure that they are continuing breathing exercises, pacing their activities, avoiding temperature changes. A lot of patients can't tolerate cold temperatures. It tends to promote bronchospasm. And make sure these patients, if they are enrolled in pulmonary rehab classes, that they do attend these. They will help to strengthen the muscles of the upper and lower extremities and improve exercise tolerance and endurance. And Medicare does cover this expense for patients that qualify that have chronic COPD. To improve nutritional status, patients are going to tolerate high protein, high calorie, more frequent meals, to rest between meals. We don't really want these patients to have tons and tons of carbohydrates, because remember, when carbohydrates actually break down, one of the byproducts from that is elevated CO2 levels. So we need to watch that with patients. They definitely need higher in protein and higher in calorie types of foods. We want them to be well hydrated, but we need to also watch with these chronic COPD patients that they don't get into fluid volume excess. So steroids and other medications that they may be on can make the body retain fluids. So make sure that they do know if they're also placed on a diuretic, to teach them to eat foods high in potassium, such as bananas, oranges, prunes, raisins, those types of things. If they are on digoxin because of associated cardiac problems also, they need to watch for the side effects of dig, such as anorexia, nausea, discolored halos around lights, blurry vision, and different types of heart arrhythmias. Home care guidelines include promoting health with this patient with a chronic illness. Humidity within the home helps their respiratory status, so trying to get the humidity level at about 30 to 50% is going to be helpful for them, and to get them into community resources such as pulmonary rehab, support groups, perhaps hook them up with the American Lung Association, and smoking cessation programs is going to be helpful. The first NCLEX question with COPD patients looks at supplemental low oxygen therapy is prescribed for a man with emphysema. Which is the most essential action for the nurse to initiate? The correct answer here is number 4, because oxygen, or the patient is, we talked about earlier, going to be very fatigued due to their chronic emphysema, and that patient can also go into respiratory distress and failure, so we need to do frequent observations of that client. The second NCLEX question looks at the nurse instructs a client to use the pursed-lipped method of breathing, and when the client asks the nurse about the purpose of this, the correct answer there is number 4. That will help to promote carbon dioxide elimination, and remember, these patients tend to have too much CO2 on board, so that would definitely be a benefit for these patients.